class. Today the topic will be cognitive neurology and classic concepts. I'm Dr. Sreenivas, consultant neurologist, GSL Medical College and Sri Padma Madhav Neuro Super Specialty Hospital, Rajahmundry, Andhra Pradesh. I'm also the author of the book Focused Neurology. I also have my own YouTube channel, Dr. Sreenivas Medical Concepts, with about 225 neurology videos for free and about 6,720 subscribers and more than 170,000 views. Yeah, first of all, I would like to pay special thanks to White Army and Dr. Kishan Rao, who has been instrumental in bringing me onto this platform. Thank you, sir. Yeah, there's a program called as SHINE, Specialized Highly Intensive Neuro Education, being conducted every year for DM Neurology and MCH Neurosurgery postgraduate students in Chennai. Dr. Lakshmi Narasimhan, the Madras Medical College HOD Neurology, conducts this program. And I'm very happy to say that I've been one of the 100 Indian neurologists invited to train DM Neurology and MCH Neurosurgery PG students. And one of my landmark achievements is that the Rule of 17 Cranial Nerves YouTube video by Dr. Sreenivas is the second most searched and popular video in the world, source Google. Yeah, this is Dr. Sreenivas Medical Concept, my own YouTube channel. The individual parts like frontal lobe, parietal lobe, temporal lobe, or occipital lobe, if you want to have details, you can come back to my channel, subscribe, and watch it at leisure. Yeah, these are all the other achievements. And this is the book I've written, Focused Neurology, Dr. Sreenivas Medical Concept, Dr. Sreenivas. This book is available online from all popular bookshops, including Amazon. Yeah. Now let's get back to the topic, cognitive neurology. If you have any doubts or suggestions or comments, you can mail to my email sreeklpm@gmail.com, or you can post your comments on my YouTube channel, Dr. Sreenivas Medical Concepts. Right. Cognitive neurology. I feel this is one of the most fascinating topics in entire neurology. Higher functions, the Hemi Neglect, revisualization, the speech, all these are such fascinating topics. I'm very eagerly waiting as much as you people to discuss this cognitive neurology. The history of cerebral localization. Certain areas of cerebral cortex have specific functions. Like Broca's aphasic patient, 1861, demonstrated that speech functions were localized to the left inferior frontal gyrus. Hughlings-Jackson was the first to point out that there is a motor cortex. Cerebral lateralization. We need to understand a very important concept, dominance. Dominance. For example, the language or the speech centers are lateralized to the left side of the cortex. So that cortex, which has got the language areas, is known as the dominant cortex. So for almost all the right-handers, more than 90% of the right-handers, the speech centers are situated on the left side of the cortex, what we call it as the dominant cortex. But the right side of the cortex is specialized for the spatial orientation. So the hemisphere to which a function is lateralized is said to be dominant for that function. Left hemisphere is dominant for spatial function and right hemisphere for spatial function. Left hemisphere for speech function and right hemisphere for spatial function. For most of the right-handers, the language areas are situated on the left hemisphere, and therefore generally left cortex is called as the dominant cortex. The human beings owe their commanding position in the animal world because of two facilities: the language and intelligence. Second, the manual dexterity, the way we manipulate our fingers. We owe a commanding position in the animal world because of two reasons. One, the language and intelligence. Second, the way we use our fingers, which is known as manual dexterity. No animal in the world can use fingers or manipulate fingers like human beings. Yeah, so we'll begin with the frontal lobes. The frontal lobes are often conceived to be the human being's supreme evolutionary attainment. The frontal lobes lie anterior to the central sulcus and superior to the sylvian fissure. Blood is supplied to the medial parts of the frontal lobe by the anterior cerebral artery and to the convexity by the superior division of the middle cerebral artery. The underlying deep white matter is supplied by the lenticulostriate arteries of middle cerebral artery. The clinical important areas of the frontal lobe include the motor strip, the premotor and supplementary motor areas, the prefrontal region, the frontal eye fields, and the motor speech area. The frontal lobe anterior to the premotor area is referred to as the prefrontal cortex. So you can see the diagram here. The frontal lobe is in the anteriormost part. It is above the sylvian fissure. So this is the frontal lobe, which we are going to discuss now. The portions of the frontal lobe anterior to area 6, area 8, and the motor speech centers are areas referred to as the prefrontal cortex. In fact, the prefrontal cortex is very much well developed in human beings. You are what you are because of the prefrontal lobe. Each individual is unique in his thinking and his behavior. That is because of the prefrontal lobe. It is well developed in human beings. Your abstract thinking, judgment, insight, planning, the intelligence, basically the real intelligence lies in the prefrontal cortex. The prefrontal cortex is the main projection site for the dorsal medial nucleus of the thalamus. It receives dopaminergic fibers and are associated with attention, short-term memory, reward, planning. Clinically, the prefrontal region can be divided into the dorsolateral prefrontal cortex, the medial prefrontal cortex, and the orbitofrontal cortex. These brain areas are highly developed in humans, and they long have been considered the seat of higher intellectual functions. Much of the information about the functions of the frontal lobe and the association areas has come from examination of Mr. Phineas Gage, a 25-year-old railroad worker who sustained severe damage to his frontal lobes when a metal tamping rod was blasted through his head after a freak accident. So Mr. Gage, when he was working on near the track, metal went and hit onto his frontal lobe, and his frontal lobe was not functioning. And therefore, all the manifestations of the frontal lobe, or rather the dysfunction of the frontal lobe, we have analyzed after taking this person, Mr. Gage. So according to Mr. Harlow's who was associated with Mr. Phineas Gage, he was no longer Gage. The person before accident and after accident, because of the frontal lobe injury, he became totally different. How different he was the main topic of the lot of these scientists of that particular era who started analyzing the frontal lobe functions. He reportedly became irreverent, lacking respect, profane, no respect for religious practices, impatient, and unable to hold job, and died 13 years later. Yeah. Dorsolateral prefrontal cortex is important in the organization of the self-ordered tasks, working memory, executive functions. Executive functions, the ability to plan, carry out, and monitor a series of actions intended to accomplish a goal. You have joined MBBS, so you make a series of plans. How to pass your MBBS exam? First year, you have to study anatomy, physiobio. Second, other subjects, final medicine, surgery, you need to concentrate on these subjects. So you make plans, a goal-directed behavior. That is known as executive function. In fact, there's a very interesting apraxia known as ideation apraxia, which I'll be talking in a few minutes from now, where this series or the sequence of acts to achieve a goal is lost. So they go out of sequence. What is out of sequence? For example, when we want to brush, we take a brush, put a paste, and then start brushing. These persons with ideation apraxia who cannot perform an act in a sequential manner, who go out of sequence, may take the brush and start brushing and then take it out and then put paste. So they go out of sequence. Very, very fascinating, ideational apraxia. This is because the series of actions intended to accomplish a goal gets affected. The prefrontal region plays a role to predict the consequence of actions, emotional expression, go, no-go, decision-making, personality, sense of time, thinking. The ventral lateral prefrontal cortex is concerned with mnemonics and processing of objects. We have the medial prefrontal cortex. It is important in auditory and visual associations. We have orbitofrontal cortex, which has important connections with the limbic system, including the amygdala. Amygdala is very important for the memory of fear. We are afraid of our seniors. In fact, we should be afraid of seniors. Then only there'll be discipline. It is because of amygdala. The moment amygdala is removed, we lose fear. In fact, there have been elegant experiments done by Kluwer and Busey, who removed amygdala from monkeys, known as Kluwer-Busey syndrome, which you must have been familiar with. Normally, monkeys and snakes are enemies, hostile. But once they removed amygdala from monkeys, they became very friendly with snakes and started playing with snakes and putting snakes over their necks. So amygdala is responsible for the memory of fear. So they have disinhibition syndromes ranging mildly from inappropriate social behavior to fully blown mania may occur with dysfunction of orbitofrontal cortex, especially of the right hemisphere. Frontal lobe dysfunction. At the age of 35, a previously healthy patient, EVR, underwent removal of a large orbitofrontal meningioma. Although surgical recovery was uneventful, his behavior, judgment, and social interactions were very much impaired. He collected outdated and useless items. So frontal lobe, the goal-directed behavior, you have 4 specific steps. 1, there's a specification of a problem, formulation of a plan initiated in an orderly sequence, then execution, comparing the results against the original plans. This is how our human beings beautifully starts functioning. We know how to go towards a problem, how to find a solution for the problem. We go in a sequential manner. We have a plan and then we try to execute it. Dominant apraxia, dominant hemisphere. This causes apraxia. Basically, there are 3 important apraxias: ideational apraxia, idiomotor apraxia, kinetic limb apraxia. Very, very interesting. This is what I just mentioned. Ideational apraxia, the orderly sequence is affected. The lesion may be in the supplementary motor area. They are crucial for the temporal organization of multiple movements. So activities of daily living are affected. You give a brush, they brush and then they take it out, put a paste. So they cannot perform activities of daily living. Activities of daily living are affected. You ask them to smoke, they take a cigarette correctly, but instead of lighting their cigarette, they may light other person's cigarette. So it is completely out of sequence. This is ideational apraxia. Activities of daily living are impaired. Idiomotor apraxia. There may be disconnection between the language centers that understand the command and the motor areas which are asked to carry it out. So imagination of an act cannot be done, but with real object, that act can be performed. The planning, the language area and the visual areas, they make the plan for a movement, but the actual movement is done by the frontal lobe. So when there's a disconnection between the language areas and the actual motor act done by the frontal lobe, a disconnection results. So what happens? The planning is gone. So you ask them to imagine as if they have taken a brush and brushing their teeth, they can't. A planning, when there's no real object, they can't. But when you give a real object like brush and paste, they start brushing. You ask them to imagine and then smoke, they can't. But give them a cigarette and then ask them to smoke, they can. So with the real object, they can perform. but when they are asked to imagine and perform, they can't. Since with real object, they can perform an activities of daily living are not impaired. They can perform their activities of daily living. In fact, it is a doctor who picks up the complaint. The patient does not volunteer because there's no limitation of activities of daily living. With real object, he can perform. Only when he's asked to imagine, he can't. This is idiomotor apraxia. Very, very interesting. Then we have the kinetic limb apraxia, the natural kinetic melody or smoothness of transition from one hand position to the next is disrupted, and there's a tendency to perseverate. So these apraxias, ideation apraxia, idiomotor apraxia, kinetic limb apraxia are seen in the dominant hemisphere, parieto-frontal connections. We have other apraxias like dressing apraxia, constructional apraxia. You ask them to dress, put on a shirt, they may put it on the wrong side, or ask them to put a trouser, they may put it upside down, or constructional apraxia, ask them to construct, they can't. These are more to do with the spatial orientation actually. They are because of disturbances in spatial orientations. So dressing apraxia and constructional apraxia are found in the non-dominant hemisphere, whereas ideation apraxia, idiomotor apraxia, and limb kinetic apraxia, they are found in the dominant hemisphere. Yeah, then we have other functions like abulia. It refers to difficulty in initiating and sustaining spontaneous movements and reduction in emotional responsiveness, spontaneous speech, and social interaction. It is characteristic of frontal lobe and basal ganglia lesions. Akinetic mutism, extensive bilateral prefrontal lesions may culminate in akinetic mutism, a state of persistent unresponsiveness. Emotional lability may be prominent. Yeah, this is about the prefrontal cortex, which is highly developed in human beings. It is because of that we are intelligent and placed at a higher level when in the animal kingdom. Then we have the motor cortex. The motor cortex is the corticospinal tract to do with the movements. So the motor area of the frontal lobe, including the primary motor cortex, as well as the premotor and the supplementary motor areas. The motor cortex contains large motor neurons, that is the bed cells that give rise to the corticospinal and corticobulbar tracts. Involvement of area 4, that is the motor cortex, causes hemiplegia. So if a person comes with hemiplegia, that means the motor cortex of the frontal lobe is affected because the corticospinal tract or the corticobulbar tract arises from the bed cells in the layer 5 of the frontal cortex. The premotor cortex lies anterior to the primary cortex, squeezed between the precentral gyrus and the posterior border of the prefrontal areas, area 6. It is involved in the planning and execution of movements, particularly sequences of movement. They are crucial for the temporal organization of multiple movements. The supplementary motor area also coordinates movements between hands, and lesion in this area may cause the alien hand syndrome. The hand is not under their control. It appears as though it has got its own action and own movement and controlled by some other person. This is known as alien hand syndrome. Lesions of the more anterior and medial part of the motor cortex causes less paralysis and more spasticity and may allow the emergence of primitive reflexes such as grasping and groping reflexes. What are these primitive reflexes? Sucking reflex, avoiding reflex, groping reflex. All these reflexes are present during our infancy when we are less than 1 year old, when the frontal lobe or the parietal lobe are not matured enough. But once these lobes, especially the frontal lobe and parietal lobe, starts maturing, these reflexes will diminish. So after 1 year, these reflexes become absent. So in mature brain, these reflexes become absent after 1 year. So if these reflexes do not disappear after 1 year, that means the parietal and frontal lobes have not matured. Or once these reflexes have disappeared, but there is a re-emergence of these primitive reflexes, it makes a point that the frontal lobe and parietal lobe are damaged at a later point of time. And therefore, there's a re-emergence of these reflexes. The Sma functions in planning motor movements, such as a sequence of actions provided from memory. Yes, very interesting again. The frontal eye fields area number 8. The frontal eye fields lie in the middle frontal cortex and control movements of the eyes to the contralateral side. Destructive lesions in this area cause deviation ipsilateral, whereas epileptiform activity causes gaze deviation contralaterally. If there's a frontal eye fields area number 8, it goes and connects to the PPRF on the opposite side, and therefore it pushes the eyes to the opposite side. And therefore, if the frontal eye fields area number 8 gets affected, it cannot push the eyes to the opposite side. Eyes will move towards the same side. And since the corticospinal tract coming from the frontal lobe has crossed to the opposite side, hemiplegia will be on the opposite side. So eyes looking to one side, hemiplegia on the opposite side is a frontal lobe lesion. Frontal eye fields area number 8 has been affected. Whereas if it is a pontine lesion, PPRF pulls eyes to its side. So when the PPRF is affected, eyes will go to the opposite side. Hemiplegia also will be in the opposite side. So eyes will be looking towards the side of hemiplegia. And a pontine lesion, eyes looking one side and hemiplegia on the opposite side is a frontal lobe lesion. On the contrary, instead of destructive lesion, if the frontal eye fields area number 8 gets stimulated like electrical activity or seizures, eyes will be pushed to the opposite side. The motor speech areas lies in the inferior frontal gyrus anterior to the motor strip. Lesion in this area causes Broca's aphasia. The language, as I said, the language and the way we use our fingers places us, the human beings, at the highest level in the animal kingdom. The language basically contains 3 important components. Comprehension. Suppose someone asks my name. What is my name? Mr. X. It goes to the ear. It goes to the vernix area. Vernix area is responsible for understanding the speech, comprehension. Okay, it thinks, okay, he's asked me my name, I have to tell my name. Then it goes to the arcuate fasciculus, to the Broca's area. Arcuate fasciculus is responsible for repetition, and Broca's area is responsible for fluency. The normal word output per minute is 100 to 115 words per minute. In Broca's area, it gets reduced to 10 to 15 words per minute. So Broca's aphasia, fluency is affected. They understand, but they can't speak fluently. Suppose they ask, what is my name? I want to say my name is Mr. X. I'll say my name X. So it is a very sensible speech, but non-fluent speech, and they are depressed because they know they are suffering from the disease. And they have hemiplegia because the frontal cortex gets affected. Broca's area is in the frontal lobe. They'll have hemiplegia. So Broca's aphasia is a sensible but non-fluent speech. They are sad and depressed because they know that they are suffering from the disease, and they'll have hemiplegia. So lesion in this area causes Broca's aphasia. Whereas if vernix area gets affected, the comprehension is lost. So they cannot understand. But since Broca's area is intact, they keep on speaking. So it is a nonsense and fluent speech. Vernix aphasia is a nonsense but fluent speech. And since vernix area is in the temporoparietal area, corticospinal fibers do not get affected because corticospinal fibers come from the frontal lobe and go to the internal capsule and the brainstem. So you don't have corticospinal fibers in the temporal lobe, so they do not have hemiplegia. Vernix aphasia patients do not have hemiplegia, and the comprehension is lost, so they are very happy people. So vernix aphasic patient, nonsense, they talk nonsense but fluent speech, no hemiplegia, and they are happy, and they may have the hemianopia because the optic radiations get affected. Since they talk nonsense and don't have hemiplegia, onlookers or bystanders think that they are suffering from psychiatric disorder, and they may land up in psychiatric hospitals. So vernix aphasic patients tend to land up in psychiatric hospitals. Broca's area is supplied by the superior division of the middle cerebral artery. Vernix area is supplied by the inferior division of the middle cerebral artery. So these speech area, all the components of the speech area are localized to the left side of the cortex, what we call as a dominant cortex. But one speech component is localized to the non-dominant cortex, right side of the cortex. What is that component? It is known as prosody, the melody or intonation. So if left cortex gets affected, all the components of the speech may get affected, especially the global aphasia, except one component which is present on the right side, and that is prosody. What is prosody? The intonation and melody. For example, if you see a friend say Mr. Y who comes from US after 10 years, you'll say, oh, my friend, Mr. Y, how are you, man, saying after 10 years? You're giving emotion to the speech. That is prosody. So if right cortex gets affected, the emotional aspects of the speech gets affected and it will be a dull speech. There's no emotional component to it. So he'll say like, oh, my friend, Mr. Y, you have come after 10 years from US. I'm very happy to meet you. Dull. There's no emotion to it. So all the components of the speech are left side, but the emotional component, prosody, is on the right side of the cortex. Lesions of the frontal lobe may also cause incontinence, particularly with the involvement of the paracentral lobule. They can have gait disorders. Magnetic gait may also be seen. The medial part of the frontal lobe, you have the bladder center, so they may have incontinence of the urine. The leg area is also there in the medial part of the frontal cortex, so they may have the gait apraxia. And the immediate memory goes to the frontal cortex, so they may have the loss of immediate memory. There are certain seizures in the frontal lobe involvement. SMA, seizures arising from SMA often involves tonic posturing, that is either unilateral or asymmetric, and often accompanied by facial grimacing and automatisms, as well as vocal symptoms such as laughing or speech arrest. Whereas if it is orbitofrontal cortex, the seizures arising from OFC often involving pedaling, thrashing movements easily confused with pseudo seizures. So persons having orbitofrontal seizures may be pedaling their legs. So most of the time they think, oh, she's acting, this girl is acting, it is pseudo seizures. How come there's only the leg movement? It is pedaling. So they may mistake it to be pseudo seizures. In fact, it's an organic seizure. It originates from the orbitofrontal cortex. The dorsolateral prefrontal cortex, the seizures arise from the DLFC. They're often adversive, turning the head and eyes to the contralateral side. So when the frontal cortex gets stimulated, the frontal eye fields area number 8 gets stimulated. The eyes goes to the opposite side. So they'll be turning the eyes like this. And the head also will be turning to the opposite side because the sternocleidomastoid gets most of the supply from the ipsilateral frontal cortex. So what happens? It gets stimulated, so head also gets turned. So if it's a frontal lobe seizure, the eyes also will turn to the opposite side. Head also will be turning to the opposite side like this. So if you see a person turning the eyes and the head to the opposite side, you have the diagnosis. It is the frontal eye fields area number 8 and a frontal lobe seizure. Yeah, I've been speaking so much on the frontal lobe, but let me summarize. It's going to be very, very easy if you understand all these salient findings of the frontal lobe. At the end of every lobe, I'll summarize with the salient points. So the frontal lobe functions: personality, emotional control, social behavior, contralateral motor control, language, and maturation. The cognitive and behavioral aspects, because of effects of damage, are disinhibition, lack of initiation, antisocial behavior, impaired memory, expressive dysphasia, that is Broca's aphasia, and incontinence. Associated physical signs because of damage are impaired smell, contralateral hemiparesis because of the corticospinal tract involvement, frontal release signs, the primitive reflexes. The positive phenomena are seizures and versive head movements because of the stimulation of the sternocleidomastoid ipsilaterally. Right. Now we'll talk about the parietal lobe. This part of the cerebrum lying behind the central sulcus and above the sylvian fissure is the least well demarcated. The parietal lobe is supplied by the middle cerebral artery, the inferior and superior division supplying the inferior and superior parietal lobules. So you can see this is the parietal lobule. Very important are the angular gyrus here, because the angular gyrus is concerned with reading. So if the angular gyrus gets affected, especially on the left side, the reading gets affected. The writing gets affected. It is known as alexia with agraphia. They can have finger agnosia. They may not be able to count the fingers, and they can have right-left disorientation, which is known as Gerstmann syndrome. So the Gerstmann syndrome is well seen in persons with angular gyrus of the left cortex, left dominant cortex getting affected. So you have other important areas, especially the right parietal lobe is concerned with the spatial orientation, which we'll be seeing now. Yeah. The primary somesthetic area is, it is basically important for sensations, as frontal lobe is important for movements motor, parietal lobe is important for sensations, the spinothalamic tract, the posterior column. Finally, they go to the parietal lobe. So the primary sensory somesthetic cortex, S1 areas 3, 1, 2 occupies all but the lowest part of the postcentral gyrus, continuing on to the medial surface into the adjoining part of the paracentral lobule. S1 receives enormous projections from the ventral posterolateral and ventral posterior medial nuclei of thalamus. So basically, parietal lobe is concerned for the is concerned with the perception of sensations. These relay impulses from the spinal thalamic tract, that is the pain and temperature, posterior column medial lemniscus, that is position joint vibration sense, and trigemino-thalamic tract, that is the facial sensations, which send fibers to the posterior limb of the internal capsule, the post-central gyrus. Body regions are represented in specific parts of the post-central gyrus. The pattern roughly parallels the motor homunculus localization of the pre-central gyrus, but is not as well defined. So you have the sensory parts of the entire body or entire body being represented in the parietal lobe. So these are not to do with the quantity, it is to do with the quality. For example, the representation of the lips and the fingertips are highest in the parietal lobe, and therefore the 2-point discrimination is very well appreciated in the lips and the fingertips because they have a very big representation in the sensory homunculus of the parietal lobe. Likewise, the motor homunculus in the frontal lobe, the representation is according to the quality, not according to the quantity. We have a big thorax, but the representation is very small. The leg area, moderate representation, but the representation is highest for the face and the fingers. The representation is highest, and therefore any lesion, any small lesion will tend to affect the face and the fingers more. They have the highest representation because we have the highest level of functional activity going on in the face, facial expressions, and the fingers. As I said, manual dexterity and language places us in the highest in the animal kingdom. So 2-point discrimination is the highest in the lips and fingertips because the sensory homunculus has got the highest representation of these areas in the sensory homunculus. Cortical sensations. Parietal lobe regions produce abnormalities of higher level sensory functions which require association cortex. The basic sensations like pain and temperature are carried by spinal thalamic tract. Touch, position, joint vibration sense are carried to the posterior column till the level of thalamus. From the level of thalamus to the parietal lobe, there are certain sensations which are appreciated by the parietal cortex. And if the parietal cortex gets affected, these sensations are lost, which are known as cortical sensations, sensations appreciated by parietal cortex. So the sensations which are lost if the parietal cortex getting affected, the primary sensations being intact are stereognosis, graphesthesia, 2-point discrimination, and tactile localization. What is stereognosis? Give him a pen. Give him a pen and ask him with closed eyes, ask him to feel and tell. So I have closed my eyes and I'm feeling, and I can tell by feeling the pen that it is a pen. This is stereognosis. What is graphesthesia? Take his hand and put a number 6 or 8, 3. By closing his eyes, he should be able to tell what number has been written on his hand. That is graphesthesia. 2-point discrimination. The 2 points are felt individually. The closest distance wherein the 2 points are appreciated separately, individually, is the 2-point discrimination, like 2 points, one finger, and then appreciating these two as 2 different points. It is highest in the lips and the fingertips and the least on the back. Tactile localization, exact point where I've touched the person is known as tactile localization. So stereognosis, graphesthesia, 2-point discrimination, tactile localization are the cortical sensations perceived at the level of the parietal lobe. Here I want to stress on 2 important points. Stereognosis is very, very important. Likewise, you touch the person on 2 points on the 2 sides. And if a person has got a parietal lobe involvement, especially one side, he'll be able to appreciate only one side and not the other side. So all these sensations, stereognosis, graphesthesia, 2-point discrimination, and tactile localization, stereognosis is very, very important because it almost tests all the sensory pathways. So if the examiner asks you, if someone asks you, if one sensation you need to test to find out whether there's sensory abnormality or not, what is it you're going to test? The answer should be stereognosis. So for sensation, stereognosis is very, very important because it can, with one test, it can test almost all the sensory modalities. Likewise, in motor system, if the examiner asks, what is one test you want to do to find out whether there is a corticospinal tract involvement or not, you should always say pronator drift. Very sensitive to pick up the subtle hemiparesis. Pronator drift. What is this pronator drift? You need to know that there are certain muscles in the upper limb and the lower limb which are predominantly innervated by the corticospinal tract. The corticospinal tract innervated upper limb muscles, the corticospinal tract innervated lower limb muscles. The corticospinal tract innervated upper limb muscles are deltoid, external rotators of the shoulder, triceps, extensors of the wrist, extensors of the finger, and supinator. Because all these muscles are involved, including supinator, so when the corticospinal tract gets affected, the supinator becomes weak. So the opposite, the antagonist pronator will take over and there is pronator drift. Because the corticospinal tract innervated muscle supinator is weak, the opposite antagonistic muscle pronator takes over and there is pronator drift. So one test which is very, very useful to detect subtle hemiparesis is pronator drift. The corticospinal tract innervated lower limb muscles are hamstring, hip flexors, dorsiflexors of the foot, and dorsiflexors of the toe. So we need to know the corticospinal tract innervated muscles. And for motor system, one test which is very, very important to even pick up subtle hemiparesis is pronator drift, and one sensory test to pick up any abnormality of sensory pathways is stereognosis. Very important concepts. That's why it's known as classic concepts of cognitive neurology. Yeah. Now again, I'm coming to another important concept. How come we see hemi neglect only in the right side of the cortex, but not with the left side of the cortex? Why hemi neglect or the spatial orientation is predominantly confined to the non-dominant cortex and not to the dominant cortex? The right cortex controls both the right and the left extrapersonal space, whereas the left cortex controls only the right extrapersonal space. So when the left cortex gets affected, the right extrapersonal space is affected, but this is compensated by the intact right parietal lobe, which controls both the right and the left extrapersonal space. So left parietal lobe lesions, they do not develop right hemi neglect. But if right parietal cortex gets affected, both the right and the left extrapersonal space is affected. The right extrapersonal space is compensated by the intact left parietal lobe, but there's no compensation on the left side. Beautiful, interesting, exciting concept. That's why only the non-dominant or right parietal cortex produces left hemi neglect, and usually the left parietal lobe does not produce right hemi neglect. So you can see in the diagram how the right parietal lobe controls both the right and the left parietal lobe controls only the right, and why right hemisphere causes a left hemi neglect and why left hemisphere does not cause the neglect. So how do you test at the bedside? You can see the other diagram, the corresponding diagram, where you ask the patient to put all the 12 numbers of a clock. So a person has got a right parietal lobe lesions. He completely neglects the left side of the clock and puts all the 12 numbers on the right side. You can see in the diagram, the numbers on the clock, all the numbers are put on the right side. He completely neglects the left side. This is known as left hemi neglect. Hemi neglect. This is how you test. And if the defect is so much severe, they may even deny the existence of the left side of the body, which is known as anosognosia. You pinch his left side of the body, he'll ask, whose hand you're pinching at? It's not my hand. Whose hand it is? If you start throwing, you say, oh, someone is throwing the other person's body. He denies the existence of the left side of the body. This is known as anosognosia. Denial of disability, culminating in denial of owning their own contralateral limbs. So hemi neglect, anosognosia are very characteristic of right parietal lobe lesions. You can demonstrate by putting the numbers of the clock. They put all the numbers on one side and completely neglect the left side of the clock. Gerstmann syndrome, this is what I said. The angular gyrus is especially important for reading. So when the angular gyrus gets affected, they develop alexia, reading, and they can have associated agraphia. You have alexia with agraphia in Gerstmann syndrome. Alexia without agraphia in a left PCA infarct where the occipital lobe and the splenium of the corpus callosum gets affected. They have alexia without agraphia. They can write, but they cannot read what they have just written. That is known as alexia without agraphia. It is seen in left posterior cerebral artery infarction, giving rise to left occipital lobe and splenium of the corpus callosum involvement, which I'll be talking further after some time. Right now, we'll be talking about Gerstmann syndrome. Angular gyrus is involved, so they have alexia, difficulty in reading, and agraphia, difficulty in writing. Because angular gyrus is important in relation to language, calculation, and spatial orientation. So they have a tetrad of symptoms: finger agnosia, right-left confusion, agraphia, and acalculia. When all components of the syndrome are present, the lesion is likely to be in the dominant inferior parietal lobe, particularly in the region of the angular gyrus. You all know that the optic radiations, they travel in the parietal lobe and the temporal lobe. So parietal lobe, if they get affected, they'll have homonymous hemianopia, but the lower part gets affected. Opposite, if the temporal lobe gets affected, they'll have also homonymous hemianopia, but they'll have superior homonymous hemianopia. So the optic radiation causes the deep parietal lobe to reach the visual cortex. A deep placed parietal lesion may either cause an inferior quadrantanopic or hemianopic visual field defect depending upon the site of the lesion. Yeah, so far I told in length about the functions of the parietal lobe, but let's summarize. So we'll summarize and then we will know the important salient points of the parietal lobe and its dysfunction. So what are the actions? First, we need to understand the actions, then only we can understand the effects of damage. The functions, the action of the parietal lobe are language, calculation. Especially we are talking about the dominant parietal lobe. The cognitive and behavioral aspects are dysphasia, agraphia, dyslexia, difficulty in reading, acalculia, they can't calculate, apraxia, they cannot perform a learned motor movement despite motor, sensory, comprehension, coordination being normal, agnosia, asimultaneous agnosia. The associated physical signs are contralateral hemisensory loss, astereognosis, agraphisthesia, contralateral homonymous lower quadrantonopia, asymmetry of optokinetic nystagmus. The positive phenomenon are focal seizures. Coming to the non-dominant parietal lobe, the summary, the actions, the functions are spatial orientation and constructional skills. The cognitive and behavioral aspects are the neglect of the contralateral side, spatial disorientation, constructional apraxia, and dressing apraxia. The associated physical signs because of the damage are contralateral hemisensory loss, astereognosis, agraphisthesia, contralateral homonymous lower quadrantonopia, asymmetry of optokinetic nystagmus, and the positive phenomenon are focal sensory seizures. Yes. Now let's go to the third lobe, the occipital lobes. The occipital lobes are the termini of the geniculocalcrine pathways and are essential for visual perception and recognition. So someone says occipital lobe, immediately think of vision. They are primarily responsible for analyzing the visual perception and recognition. The medial surface of the occipital lobe is demarcated from the parietal lobe by the parieto-occipital fissure. On the lateral side, there's no sharp demarcation from the posterior temporal or parietal lobe. On the medial side, the calcrine fissure, which causes in the anterior posterior direction, is the major landmark. The calcrine cortex on each side is the terminus of the geniculocalcrine pathways. So here you can see the occipital lobe demarcated from the parietal lobe and the temporal lobe. And in occipital lobe, we basically have the area number 17, 18, and 19. 17 is the main area for perception of the vision, but 18 and 19 are the visual association areas. They are important for analyzing, they're important for revisualization. For example, if area 18 and 19, especially if 19 gets affected, they can read a word letter by letter, but then immediately after reading, they do not have visual memory and they cannot interpret the entire word. For example, shine, they can say S-H-I-N-E. They can read letter by letter, but the word immediately they can't say it is shine. Revisualization process is gone if the visual association cortex, especially area 19, is affected. Now we'll see the details. The occipital lobe functions mainly in the receptive areas for the visual stimuli, area 17, and their recognition, area 18 and 19. Occipito-temporal lesion causes an inability to identify objects. What of visual processing is affected, and occipito-parietal lesion causes an inability to locate the objects. Where of visual processing is affected? Very, very interesting. You have the occipital lobe, you have the temporal lobe, you have the parietal lobe. You have the dorsal stream, occipito-parietal lobe, you have the ventral stream, occipito-temporal lobe. Occipito-temporal lobe is concerned with what of vision? What of vision? Classic example is prosopagnosia. They cannot identify the face of an individual, inability to identify a known face. Prosopagnosia, what of vision is lost? In fact, if the lesion is severe enough, they cannot identify their own faces when they stand in front of the mirror. So occipitotemporal lesions, especially fusiform gyrus, what of vision is lost? Classic example is prosopagnosia. Whereas if occipitoparietal area is affected, where of vision is lost, locating the object is lost. For example, if they are asked to look at the forest, they'll be focusing on only one entity like tree. They'll be missing the entire forest for the tree. They can focus on individual objects, but they cannot look at its entirety. They cannot locate the objects. This is known as asimultanagnosia. So occipitotemporal lesions, what of vision is lost? Occipitoparietal lesions, where of vision is lost? The occipital lobes are supplied almost exclusively by the posterior cerebral arteries and their branches. A small area of the occipital lobe receives blood supply from the inferior division of the middle cerebral artery. This assumes importance in the clinical finding of macular sparing. Macula is very important for central vision. In occipital lobe lesions, there could be macular sparing because macula is supplied not only by the posterior cerebral artery, but also by the middle cerebral artery. The primary visual cortex is located on the lips of the calacrine fissure and adjacent portions of the cuneus above and the lingual gyrus below. Area 17 receives the geniculo-calacrine projection, which is retinotopically organized. The striate area receives primary visual impressions, that is the color, size, form, motion, and illumination. The most familiar and classic deficit is a congruous contralateral macular sparing hemianopia with a preserved optokinetic nystagmus response and pupillary light respect. If it's an occipital lobe lesion, the vision is lost, but pupillary reflex is present. Because a pupillary reflex, even before the lateral geniculate body, it crosses to the midbrain and then goes to the pupillary fibers. So it does not go till the level of the occipital lobe. And therefore, if there is a lesion is in the occipital lobe, vision is lost, homonymous hemianopia, but pupillary light reflex is spared. So if pupillary light reflex is intact and vision is lost, it is an occipital lobe lesion. If pupillary reflex are affected, but vision is intact, it is a midbrain lesion because the pupillary reflex goes to the midbrain. If both are affected, that means it is anterior to the lateral geniculate body. So by just knowing the vision and pupillary light reflex, we can place the lesion. Vision is affected, pupillary light reflex is intact, occipital lobe. Pupillary light reflex is affected, but vision is intact, it is in the midbrain. Both are affected, it is anterior to the lateral geniculate body. Ictal activity or electrical stimulation of the calacrine cortex produces unformed visual hallucinations such as photomass and flashes of light. The parastriate region area 18 and the peristriate region 19 receive and interpret impulses coming from area 17. So impulses go to the 17, from there 18 and 19, which tries to analyze. Area 18 and 19 are visual association cortex, essential for recognition and identification of objects. They produce visual agnosias. The posterior part of the lingual and fusiform gyrus are important for color vision. The posterior portion of the middle temporal gyrus is involved in the recognition of movement, motor vision, and the fusiform gyrus is important in facial recognition. The visual memories are stored in the association cortex, and therefore if they get affected, they cannot read or remember what they've just read, S-H-I-N-E, but they cannot make a word out of it. Stimulation of these regions cause formed hallucinations. Lesions involving the occipital lobes bilaterally results in various degrees of visual loss, often accompanied by Anton syndrome, denial of blindness, and therefore they bump into objects. They are not aware that they lost vision, so they go and bump into objects. Denial of illness, which is known as Anton syndrome. The visual agnosias, occipital lobe, as I just made a mention in the parietal lobe, they are concerned with the visual agnosias, occipitoparietal, occipitotemporal. Several syndromes involving visual dysfunction are due to lesions that span the occipital lobe and either the adjacent temporal or parietal lobe. They have been divided conceptually and anatomically into a dorsal occipitoparietal and a ventral occipitotemporal stream of information processing. The ventral occipitotemporal region is considered to represent the what of visual processing to identify objects. They include visual object agnosia, prosopagnosia, alexia, and color agnosia. The dorsal occipitoparietal region is concerned to represent where of visual processing to locate objects. They include visual simultaneousness. They cannot integrate the center with the periphery of the vision, and therefore they miss the forest for the trees. Topographagnosia and balance syndrome. The visual object recognition, Lisha's concepts. Accordingly, it has two distinct processes. One, perception, the construction of a perceptual representation from vision, and a perception, the mapping of this perceptual representation into stored concepts or engrams of the object functions and the associations. According to Lisha, impairment of either of these processes could give rise to a defect in visual object recognition. Prosopagnosia. Prosopon means face, gnosis means knowledge. It's a type of visual defect in which the patient cannot identify familiar face by looking at either the person or a picture, even though he knows that face is a face and can point out its features. Lesion is bilateral lesions of the ventromedial occipitotemporal regions. They can have environmental agnosia, loss of environmental familiarity, topographagnosia, inability to orient themselves in an abstract spatial setting. Alexia without agraphia. This is occipitotemporal lesions. To understand this principle, we need to understand the concept. First of all, what is alexia? Difficulty in reading. What is agraphia? Difficulty in writing. Alexia without agraphia. They have difficulty in reading, but they have no difficulty in writing. So, for example, they write their name, for example, Mr. X, but they cannot read what they have just written. This is a beautiful concept. Alexia without agraphia, difficulty in reading, but no difficulty in writing. They can write, but they cannot read what they have just written. Alexia without agraphia. To understand this concept, you need to understand one principle. The language areas are on the left side. I'm a right-handed, so my language areas are on the left side. So when I look on the right side of vision goes into my left occipital lobe. My language areas are also on the left side, so it easily accesses to the language area, which is on the same side. So I can convert whatever I see on the right side into a language form easily. But when I look at the left side, it goes to my right occipital cortex. But my language areas are on the left side. So it has to cross the corpus callosum and then access the language areas. So when I look at the left side and convert it into a language forms, it takes a slightly longer time because it goes to my right occipital cortex. To access the language areas, it has to cross the corpus callosum and then go to the language area, which is on the left side. It cannot go directly because the language areas are on the left side. Very important. Right side of the vision goes to the left occipital cortex. Language areas are also on the left side. It easily access. Left side of the vision goes to the right occipital cortex. It is difficult to access the language areas because it is on the left side, whereas the vision here on the right side. Very important. If you understand this principle, understanding alexia without agraphia is very, very easy. Alexia without agraphia is because of the left posterior cerebral artery involvement, a lesion of the posterior cerebral artery. So the left posterior cerebral artery gets affected, person will have left occipital cortex infarct. So they cannot see anything on the right. They have right homonymous hemianopia. So whatever has to be seen through the right occipital cortex. So left PCA infarct not only causes left occipital lobe infarct, but also the splenium of the corpus callosum gets affected. So anything on the left side, they can see it goes to the right occipital cortex, but they cannot convert it into a language form because it cannot traverse the corpus callosum because the splenium of the corpus callosum is also affected. So they cannot convert what they see on the right side, on the right cortex, into a language which is on the left side because the splenium of the corpus callosum is also affected. Because of that, they cannot read. Writing is not affected because it goes slightly anterior to the splenium of the corpus callosum. So alexia without agraphia is seen in the left posterior cerebral artery, producing lesions or damage at two sides. One, left occipital cortex. Second, the splenium of the corpus callosum. So the information from the right occipital cortex cannot access the language areas, which is on the left side. So alexia without agraphia. With destruction, you can see this diagram. You can see that there are two lesions, one in the occipital cortex, second in the splenium of the corpus callosum. So the destruction of the left visual cortex and the splenium or the intervening white matter, the words perceived in the right visual cortex cannot cross over to the language areas, which is around the left side, and patients cannot read. Very fascinating concept. As I said, occipitoparietal lesions causes simultanagnosia. Where of the vision is lost. They cannot integrate the center of the vision with the periphery of the vision. So for example, here is, you can see in the diagram, there are big A's and small A's. You ask them to encircle A's. Generally, we'll be able to see big A's. But persons with asimultanagnosia, when they see small A's, it falls into within the center of their gaze and they encircle it. But when they see big A's, they see either the horizontal line or the oblique line, because they cannot integrate the center of the periphery of the vision, and they think they are not A's. So they'll not be able to understand the big A's, and therefore they miss out the big A's and they don't encircle, they encircle the small A's. Very fascinating. Generally we encircle big A's, but here are the persons who encircle small A's and they cannot identify the big A's because they cannot integrate the center of the vision with the periphery of the vision. This is visual asimultanagnosia. They ask to look at the forest, they'll be looking only at the tree and not the forest in its entirety. They'll miss the forest for the tree. So visual asimultanagnosia describes an inability to grasp the sense of the multiple components of a total visual scene, despite retaining ability to identify individual details. When asked to encircle A's, patient encircles only small A's and not big A's. It's a syndrome, balance syndrome. You have optic ataxia, oculomotor apraxia, and visual asimultanagnosia. They are the components of the balance syndrome. This is balance syndrome. Balance syndrome, an essential feature of balance syndrome, appears to be a failure to properly direct oculomotor function in the exploration of this space. It is typically seen in patients with bilateral parieto-occipital lesions, where of vision is lost. It consists of a triad of optic ataxia, difficulty in grasping or touching an object under visual guidance as though hand and eye were not coordinated. Optic apraxia, an inability to project gaze voluntarily into the peripheral field and to scan it, despite the fact that the eye movements are full. And finally, simultanagnosia, it is characterized by an inability to appreciate the overall meaning of a complex picture or stimulus with preserved perception of isolated elements or details within the stimulus, misses the forest for the tree. So balance syndrome is a triad: optic ataxia, optic apraxia, and asimultanagnosia. So finally, again, as I did for the frontal lobe and parietal lobe, the summary of the occipital lobe: action and effects of damage. The actions or the functions of the occipital lobe are visual processing. The effects of damage could be cognitive behavior, associated physical signs, or positive phenomena. The cognitive and behavioral are visual inattention, visual loss, visual agnosia. The associated physical signs are homonymous hemianopia, the macular sparring, and the positive phenomena are simple visual hallucinations, example, phosphines and zigzag lines. Now we go to the final lobe, the temporal lobe. The Sylvian fissure separates the superior and lateral surfaces of the temporal lobe from the frontal lobe and from the anterior part of the parietal lobe. The temporal lobe merges posteriorly with the occipital lobe and superior laterally with the parietal lobe. The inferior branch of the middle cerebral artery supplies blood to the convexity of the temporal lobe, and the temporal branch of the posterior cerebral artery supplies the medial and inferior aspects, including the hippocampus, and therefore they can have memory deficits, because hippocampus is very, very important for memory. So this is the temporal lobe. You can see it underneath the Sylvian fissure. So what are the clinical effects? One, it is concerned with special senses: visual, auditory, olfactory, and gustatory. It is concerned with the language, especially the vernix area, memory, the hippocampus, and the time perception, emotion, and behavior. The temporal lobe includes the superior, middle, and inferior temporal, fusiform and hippocampal convolutions, and on its superior surface, the transverse gyre of Heschel, which is important for auditory processing, which constitutes the auditory receptive area. Hearing is represented bilaterally, so that Heschel's gyre of both temporal lobes need to be affected to cause cortical deafness. Cortical deafness is unusual because the representation is bilaterally. One lesion which can cause cortical deafness is the ICA, the labyrinthine artery of the anterior inferior cerebral artery. If it gets affected, you can have cortical deafness. But by and large, there is no cortical deafness because the hearing is represented bilaterally. The hippocampal convolutions is of critical importance in learning and memory. Short-term memory and converting the short-term into long-term memory, hippocampus is very, very important. But unlike the six-layered neocortex, the hippocampus and the dentate gyrus are typical of the phylogenetically older layered allocortex. So instead of 6, they have only 3 layers. The hippocampus and cerebellum are very, very important, especially in terms of dependence on oxygen. They are highly susceptible to hypoxemic conditions. Though hypoxemia affects the cortex in general, it specifically affects the hippocampus and the cerebellum. And therefore, persons who recover from hypoxic encephalopathy will have memory deficits because hippocampus is affected, and they'll have cerebellar signs because cerebellum is affected. So hippocampus and cerebellum are very much dependent on oxygen, and hypoxemic encephalopathy especially affects the hippocampus and cerebellum, causing memory deficits. Amygdala is important for the memory of fear, and if amygdala is removed, there's no fear. And the Kluwer-Bucy experiments, the monkeys become very friendly with snakes, which are generally considered as their enemies. The inner stream of talk, constant thinking, is also thought to be in temporal lobe. Very fascinating. Have you ever realized that when you are in parties and talking to friends, the language is external stream of talk? Hi, how are you? When did you come? This is how you talk. But when you are not in a party, when you're sitting alone, or when you're preoccupied, you're not quiet. There's an inner talk going on. Inner talk, inner stream of talk, constant thinking. Whatever you're thinking is in terms of language. So we call that as an inner stream of talk, constant thinking. So when you're sitting alone or preoccupied, you are not quiet. You are constant language. Inner talk is going on in yourself in the form of language, that is the thoughts. This is known as inner stream of talk, and it is thought to be in temporal lobe. Very interesting. You might notice when you're sitting alone or preoccupied, you're constantly talking to yourself in the form of language, the inner stream of talk. Kluwer-Bucy syndrome, as I already said, bilateral ablation of the temporal lobe. It causes individuals to put objects in their mouths and engage in appropriate sexual behavior. In inappropriate sexual behavior, because the memory of fear is lost, so they have no inhibition, they have disinhibition. Other symptoms including loss of normal fear and anger responses, memory loss, visual agnosia, inability to visually recognize objects because occipitotemporal water vision is lost, seizures, distractibility, and dementia. Memory is hippocampus, so they can have dementia. A lesion in the superior convolutions of the dominant temporal lobe area 41 and 42 result in failure to understand the spoken word auditory verbal agnosia, and is an important component of the Wernicke's aphasia. So Wernicke's area, the understanding or the comprehension is lost. Broca's area, the fluency is lost. Arcuate fasciculus, if it is affected, repetition is lost. That is conduction aphasia. So arcuate fasciculus is very, very important for repetition. So if arcuate fasciculus is spared, repetition is intact. Classic example is transcortical aphasias. What are these transcortical aphasias? Transcortical aphasias are otherwise known as water zone infarcts or border zone infarcts. When there is hypoperfusion, hypotension, the proximal part of the arteries get good blood supply, but as they go distally, it does not get good blood supply. So anterior cerebral artery gets good blood supply proximally, but as it goes distally, there's not much blood supply. Middle cerebral artery gets good blood supply, but as they go distally, not much blood supply. Posterior cerebral artery proximal part is good supply, but as they go distally, there's not much blood supply. So there could be an infarction, border zone infarction between ACA and MCA, or MCA and PCA. So we have transcortical motor aphasia and transcortical sensory aphasia. So since they are placed distantly, the main perisylvian area, especially the arcuate fasciculus, is intact. And since the arcuate fasciculus is intact, repetition is intact. So transcortical aphasias are otherwise known as repetition sparing aphasias. Transcortical motor aphasia is like Broca's aphasia, but repetition is intact. Transcortical sensory aphasia is like Wernicke's aphasia, but repetition is intact. And if it is mixed transcortical mixed aphasia, the only thing which is present is repetition. Isolation aphasia, or otherwise known as echolalia. They listen and then they keep talking. Echolalia. So that's about the Wernicke's aphasia. So temporal lobe includes a large part of the limbic system, which serves the emotional, motivational aspects of the behavior and vegetative functions. The limbic system, the emotional system, the limbic system concerned with the emotion is in the temporal lobe. So if the temporal lobe gets affected, they can have emotional disturbances. That's why in complex focal seizures, they have focal seizures with dyscognitive behavior, because the limbic system gets affected. So they have altered sensorial behavior. When disease, it may cause delirium, confusional states, and psychosis. The lower fibers of the geniculocalcarein pathway from the inferior retina swing to a wider arc over the temporal horn of the lateral ventricle en route to the occipital lobes, and the lesions that interrupt them produce a contralateral upper homonymous quadrantonopia. So if parietal lobe gets affected, they'll have inferior quadrantonopia. If temporal lobe gets affected, they'll have superior quadrantonopia because the representation is opposite. Music. The non-dominant hemisphere is important for the recognition of harmony and melody in the absence of words. That is, the naming of musical scores and all semantic, written and reading aspects of music require the integrity of the dominant temporal and probably the frontal lobes as well. So recognition of harmony and melody is the non-dominant hemisphere, whereas the semantic aspects, reading and writing aspects of the music goes to the dominant temporal lobe. Vestibular disturbance. Vestibular is concerned with balance. Basically, we are all, when we stand, we have a good balance. The balance is because of three structures. One, the ocular. Second is the vestibulocerebellar. Third is the posterior column. These three systems should be intact for us to be in good balance. Even if two systems are intact, still we can maintain balance. That's why in posterior column lesions, still we don't fall because of the opta system is intact. But the moment the second system is also affected by making a person to close the eyes, you're removing the opta system also. Posterior column is also affected. Only vestibulocerebellum is intact. That is not enough to maintain balance, and person tends to fall. This is known as a Romberg sign, or test for the integrity of the posterior column. So posterior column, ocular and vestibular cerebellum are responsible for balance, and vestibular main pathway goes to the temporal lobe. So temporal lobe involvement can cause vestibular disturbances. In the superior and posterior part of the temporal lobe, the posterior to the primary auditory cortex, there's an area that responds vestibular stimulation by establishing one sense of verticality related to the relation to the environment. Otoscopy and out-of-body experience, very, very interesting. Cortical vestibular area may be associated with otoscopy, seeing oneself from an external perspective. Generally, we see from our perspective, but otoscopy, they see from external perspective, as if we see other persons, and associative but not identical out-of-body experience that has been reported by patients who have near-death experiences and episodes. They have disturbances of time perception. In temporal lobe seizure originating on either side, time may seem to stand still or to pass with great speed. You might have seen in movies also. One of the important films wherein Sridevi gets this kind of disturbance where she gets stuck at a particular age of the childhood and she does not remember things which has happened after her childhood. This is perhaps related to the disturbance of time perception. Yeah, the movie's Hindi film's name is Sadma. So this is probably related to the disturbances of time perception. So in temporal lobe seizures originating on either side, time may seem to stand still or to pass with great speed. The patient with a Korsakoff amnestic state is unable to place events in the proper time relationships, presumably because of failure of retentive memory, a function assignable to the medial temporal lobe. So they do not place events in the proper time relationships. For example, we know that say about 10 years back, we did our MBBS, 5 years back, we did our MD, and a few years back, we did our DM. We know the time sequence, but they seem to have gone out of this time sequence. So 10 years back, they think it is DM, or just 2 years back, they think it is MBBS. So out of time, they are not able to place events in their proper time relationships. So disturbances of time perception, they may get, they may probably get fixated at one particular age, and they may not move out of that age period, and they are not able to place events in the proper time relationships. So there are all kinds of disturbances in time perception. In fact, a lot of movies have been made on this particular concept. Disturbance of smell and taste. Seizures originating in the medial part of the temporal lobe in the uncus often evoke olfactory hallucinations, sometimes referred to as uncinate fit. The olfactory system and the hippocampus seem to be the oldest parts in the evolution. And once we have come at the highest level in the animal kingdom, these have been subdued in the humans, but it has been still persisting in animals. Example, dogs. They have a very good smell, but when we have gone to the highest level in the animal kingdom, these have been subdued. So olfaction, hippocampus are well seen in lower animals. So seizure foci in the medial part of the temporal lobe in the uncus often evoke olfactory hallucinations, sometimes referred to as uncinate fit. Stimulation of the posterior insular area illustrates a sensation of taste along with disturbances of alimentary function. As I said, occipitoparietal lesions, where of vision gets affected. Occipitotemporal lesions, prosopagnosia, what of vision gets affected. So occipitotemporal lesions cause a deficit of what of visual processing. They cannot identify objects. Prosopagnosia, inability to identify known faces. They cannot identify with vision, but the way they, with other senses, they may be able to identify. Differences between dominant and non-dominant temporal lobe in relationship to learning. Dominant temporal lobe lesion cause an impairment in the learning of material to the auditory sense. Non-dominant temporal lobe lesions cause an impairment in learning of material present to the visual sense. They can have disturbance of emotion and behavior. The limbic system, the medial temporal lobe is intimately connected to emotion and behavior. So finally, summarizing the functions of temporal lobe and the dysfunction because of the temporal lobe lesions are actions, that is the functions, and the effects of damage. Action, functions, and effects of damage resulting in cognitive behavior, associative physical signs, and positive phenomena. So first, let's talk about the dominant temporal lobe involvement, and then we'll move on to the non-dominant temporal lobe involvement. Dominant temporal lobe, the actions, auditory perception, language, verbal memory, smell, and balance. The cognitive behavioral effects because of the effects of damage are receptive aphasia, that is Wernicke's aphasia, dyslexia, impaired verbal memory. The associated physical signs because of the effects of damage are contralateral homonymous upper quadrantonopia, and the positive phenomena are complex hallucinations, smell, vision, and memory. When it comes to the non-dominant temporal lobe, the actions and the effects of damage, the actions and functions are auditory perception, melody pitch perception, non-verbal memory, smell, and balance. The effects of damage resulting in cognitive behavioral abnormalities are impaired non-verbal memory, impaired musical skills, the tonal perception. The associated physical sense are contralateral homonymous upper quadrantonopia, and the positive phenomena are complex hallucinations, smell, vision, and memory. So I just gave an overview of all the 4 lobes and their excellent concepts. That's why it's known as cognitive neurology and classic concepts. But if you want to know about the individual lobes and details, you can always come back to my YouTube channel, Dr. Sreenivas Medical Concepts, where I have more than 220 neurology videos for free and 6,000 subscribers. So you can subscribe to my YouTube channel, Dr. Sreenivas Medical Concepts. Yeah, this is the book I wrote. Almost all the concepts of neurology, I put it in a question answer format. This is known as Focused Neurology, written by me, S. Sreenivas. This book is available online from all leading bookshops, including Amazon. So if you want, you can book it online, Focused Neurology, especially Amazon. And once again, I thank White Army, especially Dr. Kishan Rao, who has given a wonderful opportunity to interact with students across the country. It's a wonderful opportunity for me to interact with the students across the country, and it was possible because of you, Dr. Kishan Rao. So I really thank you from the depth of my heart. Yeah, thank you once again. Thank you for the opportunity. Yeah, any questions or any doubts, I'm willing to take. And I hope I finished on time.
Thank you, sir. That was a wonderful lecture, sir. We have some few questions in comment section, sir. So, one question from Mr. Guru Prasad, sir. Can you explain the differences between conceptual apraxia and ideational apraxia?
Yeah, ideational apraxia and idiomotor apraxia. Ideational apraxia, see, there are two particular events happening here. One is the frontal lobe, which is responsible for the goal-directed behavior. Second is the parieto-frontal connections, which are responsible for planning of a movement. So in ideation apraxia, the frontal lobe, especially the dorsolateral frontal cortex, gets affected. So the goal-directed behavior is affected. So the sequential movement, the sequential parts required for a particular movement is affected. For example, if I'm given a brush and a paste, what do? I take a brush, put a paste on it, and then start brushing. This is the sequence of events to accomplish a goal of brushing my teeth. But persons with ideation apraxia, the sequence, the goal-directed behavior is gone. They go out of sequence. So they may take a brush, put a paste, and they may take a brush, start brushing, and then take out and put a brush. It does not serve the purpose. They're not attaining the goal of brushing the teeth. So they go out of sequence with real lifetime objects. So they have activities of daily living they cannot perform, because with real object, they're not able to perform. This is ideation apraxia. Activities of daily living are impaired. In idiomotor apraxia, is something like a disconnection syndrome between the parieto-frontal area and the motor area. So the planning gets affected, but since the frontal lobe is intact, they can perform with the real object. Only the planning is affected. So they are asked to imagine and then perform, they cannot. Ask him to imagine that he's smoking a cigarette. He can't take a cigarette and then imagine how to smoke. But give him a real cigarette, he'll happily smoke. So with the real objects, or give him a pen and write, with a pen and actual paper, he can write. But ask him to imagine that he's got a pen and the paper and then write, he can't. Imagination is affected, but with a real object, he can perform. This is idiomotor apraxia. With the real object, since he is able to perform the activities of daily living are not impaired. Person does not realize that he's got idiomotor apraxia because activities of daily living are not impaired because he's able to perform movement with a real object. It is a doctor who examines and then picks up the problem. So ideational apraxia, basically with the real object also they cannot perform. So activities of daily living are impaired. Idiomotor apraxia, imagination is difficult, but with the real object they can perform. So activities of daily living are not impaired. It's more like a disconnection syndrome is idiomotor apraxia. A very good question. One of my favorite topics.
Thank you, sir. Sir, again, Mr. Guru Prasad has one more question, sir. Can you explain different types of alien hands, sir?
Alien hands?
Yes, sir. Different types of alien hands, sir.
Yeah. See, alien hand is something like a sympathetic apraxia in Broca's aphasia. So here the lesion is in the left frontal area. So when the left frontal area gets affected, there is a right hemiplegia. They cannot use the right hand. So right hand is paralyzed. So when the corticospinal tract is affected, they cannot use the right hand. It is completely paralyzed. The left hand is intact because the right frontal cortex is intact. But the connection between the left frontal cortex and the right frontal cortex, the motor area, is affected. So though the frontal lobe on the right side is intact, the information coming from the left frontal cortex is affected. So though the left hand is not paralyzed, it seems to move on its own. This is known as sympathetic apraxia. If it is a very severe form, you call that as alien hand syndrome. The hand movement is not according to their wish. It seems to have its own action. That is alien hand syndrome. It is basically a sympathetic apraxia in the left frontal area, that is Broca's area. So the left frontal lobe causes a right paralysis, right hand paralysis, but left hand there is no paralysis, but it keeps on acting on its own because the right frontal lobe, the message or information coming from the left frontal lobe to the right frontal lobe is affected. So it starts acting on its own. That is alien hand syndrome. A left frontal lesion, which is known as sympathetic apraxia in Broca's aphasia.
Thank you, sir. We have another question from Dr. Aditya, sir. Why do patients with bi-temporal hemianopia complain of diplopia?
Bi-temporal hemianopia, that is pituitary tumors. Yeah.
So complaining of diplopia, sir.
Yeah, right. Good. Very good question. See, pituitary tumors, basically they have bi-temporal hemianopia. Why? Because the optic tracts come together and then cross over to the opposite side. The nasal fibers cross over, whereas the temporal fibers do not cross over. So when there is a lesion in the pituitary tumor, in the pituitary area, pituitary tumor, it goes and compresses the crossing nasal fibers. The nasal fibers represents the temporal field, so they'll have bi-temporal hemianopia. In fact, one of the very favorite questions of the examiner is giving a scenario wherein a person walks in the night or dark, a car comes with two headlights, but the person is not able to see the two headlights which are placed sideways and goes and hits the car. What is your diagnosis? The diagnosis is bi-temporal hemianopia. Because he's placed in the center, the car has got two bulbs, headlights, which are on his on his two sides laterally, temporally. Bi-temporal hemianopia, he's not able to see, and therefore he goes and hits the car. So bi-temporal hemianopia is seen in the pituitary tumor because of the impingement on the optic nerves. But then we have the cavernous sinus also, which is very close to the pituitary tumor. We have the third nerve, we have the fourth nerve, and even the subtle rectus gets affected. They'll have double vision on looking at the far off objects. And it can characteristically produce seesaw nystagmus also. Very interesting. The mechanism is not completely known. Seesaw nystagmus because of the superior rectus, superior oblique involvement. One side there is torsion, superior torsion. The other side inferior and extorsion. Then they change over and then go opposite side. This is known as seesaw nystagmus, very classically seen in the cellular masses, pituitary tumor masses. We have another interesting nystagmus wherein the dorsal part of the midbrain gets affected, pineal tumors known as Parinot syndrome, where it causes a convergence retraction nystagmus. It is a supranuclear palsy of the third nerve in the midbrain. So what happens? It is stimulation. It stimulates the opposite muscles. Both the medial recti get stimulated, so they'll have convergence, and superior rectus and inferior rectus at the same time they get stimulated, so they'll have retraction. There's no divergence because sixth nerve and pons is intact. So it produces convergence and retraction nystagmus. Convergence because the two medial recti fire together, and retraction because the superior rectus and inferior rectus fire together. So superior rectus and inferior rectus is retraction. This is known as convergence retraction nystagmus. And they'll have up gaze palsy. Because vertical gaze, there are two types, up gaze and down gaze. Up gaze fibers cross over and then descend. Down gaze fibers descend straight away. So in Parinot tumor, it goes and impinges on the top of the midbrain. So it impinges on the crossing up gaze fibers, so they cannot look upwards. So up gaze palsy, they'll be only looking downwards. Same phenomenon for hydrocephalus. It goes and impinges on the top of the midbrain where there is a crossing fibers gets affected. So in hydrocephalus, they cannot look upward, they'll be looking only downwards. It is known as sunset sign. Hydrocephalus, Parinot syndrome, you see this up gaze palsy looking downwards, known as sunset sign. So she's asked about the re-emergence of primitive reflexes. See, we have myelination also of the tracts. For example, we are born, but we don't walk till we are 1 year old or 1.5 years old. What is the mechanism? Because the corticospinal tracts with which we are born are not myelinated at the time of birth. It starts myelinating at 1.5 years. Only when corticospinal tract starts myelinating, we are able to walk. That is the mechanism. So it gets matured. The myelination starts forming and we are able to walk. Likewise, in the immature frontal and parietal lobes, they are immature. So these are primitive reflexes. That means old reflexes, primitive. It's present in a very, very young age, before our infancy. So like sucking reflex, groping reflex, avoiding reflex. So these are known as primitive reflexes. These are present and probably necessary because they have to feed. They have to take everything and eat. So these reflexes are probably necessary. That's why they are present in infancy till we are 1 year old. But once the frontal lobe and parietal lobe starts maturing, these reflexes disappear. We don't have these reflexes anymore. We don't have sucking reflex. We don't have groping reflexes. We don't have avoiding reflex. But once these frontal and parietal lobe gets affected, it could be because of degeneration or it could be any other reason, then these reflexes which were inhibited now starts re-emerging. So a re-emergence of reflexes or presence of these reflexes indicate an immature frontal and parietal lobes. Non-disappearance of these reflexes or the reflexes being disappeared and re-emerging indicates the immaturity of these lobes.
Next question is, what is the most common cause of syncope and pseudo seizure in neonate and pediatric kids simultaneously, sir?
Pseudo seizure in children. Pseudo means acting. So acting is once you become mature and cunning, only you start acting. So it's not pseudo seizure, probably mimic. You're talking about a pseudo seizure mimic. So breath holding spells, these are all seizure mimics. Pseudo seizure means they're not actually seizure, they're acting. We see it in adults, especially in girls. Why do we see more in girls as compared to guys? Because girls, they think they are emotionally deprived, especially from the parents. Parents give more importance to to boys, to sons rather than the daughters. If a son asks a bike, which is say 1 lakh, they are immediately willing to buy. But if a daughter asks a sari for 10,000, they're not willing to buy. So these daughters, girls, they feel deprived. They want some kind of emotional support from their parents. And when will a person get emotional support? When you're not well, when you're sick. So they feign illness as if they're having seizures. So the parents give them a lot of emotional support. They take them to hospital. They want that kind of support. So these are known as pseudo seizures. They are not true seizures. They are false seizures. The children, what we see, are not pseudo seizures. They are seizure mimics, like breath holding spells. There are so many pediatric conditions. Yeah.
Okay, sir. Another question.
Important thing is pyridoxine deficiency for seizures in children. Yeah.
Sir, another question, sir. What is the current management for cricoid aneurysm, sir?
No, I think we'll stick on to the cognitive neurology. Aneurysms and some other topic we'll talk. Anything regarding cognitive neurology we'll talk. Aneurysm
No,
basically they have clipping and coiling. They are two forms of treatment.
Okay, sir. Sir, another question from Dr. Guru Prasad, sir. Can you explain the differences between echolalia and palilalia and preservation, sir?
Very, very fascinating topic and question. I enjoyed. Dr. Guru Prasad, you've raised a wonderful topic because this is not well discussed in textbooks. Unless you understand this concept, you are likely to forget it. As Wernicke's area is responsible for understanding or comprehension, as Broca's area is responsible for fluency, arcuate fasciculus, which connects Wernicke's area and Broca's area, is responsible for repetition. I repeat, arcuate fasciculus is important for repetition. So as long as arcuate fasciculus is intact, repetition is intact. These transcortical aphasias, which I've just discussed, transcortical motor aphasia or transcortical sensory aphasias, because of border zone infarcts, watershed infarcts, they occur distally. So indirectly implying that the perisylvian region, which is responsible for language, especially the arcuate fasciculus, is intact. So in these transcortical areas, which spares the arcuate fasciculus, spares the repetition. So much so that the repetition is increased. So when they hear someone talking and then keep repeating, so someone say, Lalit says, sir, you gave a good talk. And then I hear it and say, yeah, I gave a good talk. You gave a good talk. You gave a good talk. That is echolalia, hearing and then speaking. I myself repeating, I gave a good talk. I gave a good talk. That is palilalia, parrot-like. So hearing and then repeating is echolalia, and repeating by my own is palilalia. Both are repeating. It indicates that the arcuate fasciculus is intact, and it is basically seen in transcortical aphasias. These are otherwise known as repetition sparing aphasias because they are distal and therefore they spare the perisylvian area, which is the main language network, especially arcuate fasciculus. If arcuate fasciculus gets affected, repetition gets affected. Example, conduction aphasia. But if repetition is spared, like your transcortical aphasias, repetition is spared. Repetition sparing aphasias, very important. Broca's aphasia, we say fluency is lost. Wernicke's aphasia, we say comprehension is lost. But transcortical aphasias, we say repetition is spared. Very important, because in MCQs, they may try to confuse you. Unless you understand the concept, you're likely to get confused.
Sir, those are the questions, sir. 1 second, sir. I think we have another question. Sir, why sudden hearing loss is a danger sign in vertigo, sir?
Why sudden hearing loss is a dangerous sign in vertigo? Generally, there's no central cause of hearing loss. As I said, hearing goes bilateral. It has got bilateral representation. So when it goes bilateral representation, a cortical lesion does not generally produce hearing loss, except ICA, anterior inferior cerebellar artery, which gives a labyrinthine artery branch, which can cause cortical deafness. So if there's a cortical deafness, that means it indicates that there's a vascular supply being impaired. It is like a stroke. So any stroke is dangerous. It is central cause, not a peripheral cause. So it's dangerous. The way to differentiate central cause from peripheral cause is one of the important ways is nystagmus. Peripheral cause is usually unidirectional. For example, if the right vestibular apparatus is stimulated, it goes and connects with the PPRF on the opposite side. So eyes will go to the opposite side, and frontal eye fields area number 8 will try to put the eyes back, so they'll have nystagmus. So stimulation by turning the head to the one side, that is the oculocephalic reflex, or by putting warm water, the eyes goes to one side and the nystagmus is to the same side. COWS, warm, same. When you put cold water and inhibit it, this side vestibular apparatus will overact, eyes will go to this side, and frontal eye fields area will try to put it back towards normal. So there's nystagmus. So cold opposite, warm same. So it is a unidirectional nystagmus. That is peripheral. Whereas if it's a central nystagmus, like cerebellum or anything, it is bidirectional. It goes one side, beats, comes and beats on the other side. This is known as periodic alternating nystagmus. Bidirectional nystagmus is very dangerous. It indicates a central pathology. Unidirectional nystagmus is less dangerous. It indicates a peripheral pathology. In fact, we make a diagnosis whether it's a peripheral vertigo or central vertigo by a mechanism known as HINS, head impulse test, and test for skew deviation. HINS, head impulse nystagmus, and test for skew. What we do, we give a pen like this. We give a pen, turn the head to one side, ask him to keep looking at the pen. For me, since my vestibular apparatus is intact, when I turn my head to the opposite side, my vestibular apparatus is getting stimulated, and therefore PPRF on this side gets stimulated, eyes will go to the opposite side. I'm able to fix on my pen. So my ocular cephalic reflex is intact. But in persons with peripheral vertigo, where the vestibular apparatus is dysfunctioning, when they turn to the head to the one side, they are not able to push the eyes to the opposite side and focus on the pen because of the vestibulo-ocular reflex. Vestibular apparatus is affected, peripheral vertigo. So the eyes also will move towards the same side of the head, and then they try to make a corrective saccade. So if you see a corrective saccade in persons with this particular sign, that indicates it's a peripheral vertigo. It is good for the patient, in fact, because it's a peripheral vertigo. There's a corrective saccade, corrective catch-up.